Hello, everyone, and welcome to today's webinar, Expanding the Global Malnutrition Composite Score measure to 18 plus. I am Laura Borth, the Policy Director for Defeat Malnutrition Today, and I am joined here today with two speakers, Bob Lancato, the National Coordinator for Defeat Malnutrition Today and Executive Director of NANAS, and Ann Coltman, the Senior Director of Quality Standards and Interoperability at the Commission for Dietetic Registration. So along the course of this webinar, feel free to ask questions in the chat, and we will have 10 or 15 minutes at the end of this webinar to answer any questions. So for today's webinar, a little hello and welcome. We'll give some background on malnutrition and a link to health equity, review the proposed rule, and cover how and why to comment. So to start off, some of you may know who we are, but Defeat Malnutrition Today, we're a coalition of over 120 stakeholders and organizations focused on creating policy change towards a greater emphasis on screening for, detecting, treating, and preventing malnutrition. As you are all well aware, or you wouldn't have been on this webinar today, malnutrition is an underdiagnosed issue. It's highest in older adults, but there are still a large number of adults 18 plus who have malnutrition-related hospital stays. And an estimated 20 to 50% of hospital patients are at risk for malnutrition, yet malnutrition is only diagnosed in less than 9% of adult hospital patients. And so malnutrition may be under the radar of care in US hospitals and possibly overshadowed by the focus on acute conditions and high-tech diagnostic and treatment strategies. Malnutrition is a care gap. Malnutrition quality measures, such as the one we'll discuss today, can improve patient health outcomes, with studies showing that malnutrition interventions started in the hospital likely decrease mortality and may improve quality of life. Malnutrition is a health equity issue, and I will let Bob take it from here.
Thank you, Laura, and welcome everyone joining us today. Malnutrition is in fact a health equity issue, and it was actually featured in an article that was written several years ago in Health Affairs that led into the adoption of the first quality measure that CMS approved. And social determinants of health contribute to risk factors for food insecurity and malnutrition, and malnutrition is directly linked to food insecurity. And we know there are substantial disparities in malnutrition diagnoses and readmissions that exist. Those disparities do exist. And as the quality measure points out, with effective screening, assessment, diagnosis, and intervention, malnutrition can be identified and addressed. Next slide. So the quality measure is hospital-based, obviously, and why start in the hospital? Well, an obvious point is the primary healthcare service point for so many in our at-risk communities around the country who actually may have fewer primary care visits. Hospitals have the infrastructure, the workflow, and the trained clinicians to conduct screening. Malnutrition, a very important point, can be and should be identified at the time of hospital admission. Then it becomes easier to refer to the appropriate professionals, improving access to needed care and timely follow-up. And hospitals can monitor and do monitor interventions for better outcomes. And what starts in the hospital can be continued at home with proper discharge planning. And Ann, I'll turn it over to Ann, I guess, at this point. Thank you.
Thanks.
Sorry about that.
Thank you. Hi, everyone. My name is Ann Coltman, as Laura mentioned. My team and I at CDR and the Academy are responsible for overseeing, we're the measure stewards for the Global Malnutrition Composite Score. So just as a high level overview, I'm sure most all of you are familiar with the Global Malnutrition Composite Score. It is the first nutrition focused clinical quality measure in a CMS reporting program. It's currently in the inpatient quality reporting program, which is a pay for reporting program versus pay for performance. So hospitals are able to self-select. They currently mandate 3 ECQMs, and then they self-select 3 other ECQMs. The GMCS is one of those that they're able to self-select from a list of 6. It currently is used for adults 65 years and older with a inpatient hospital length of stay of at least 24 hours, and contains 4 components. The first is screening for malnutrition risk. So this can be done, it's often done by nursing, maybe done by a dietitian, diet tech, or someone else on staff who's deemed competent and appropriate to do that, utilizing a validated nutrition screening tool. If a patient is identified to be as at risk for malnutrition, or they have a hospital dietitian referral, which you don't see in this diagram, but can be used sort of as a bypass for step number 1, then they should receive a nutrition assessment, which is measure observation number 2. The nutrition assessment should be done by a registered dietitian nutritionist because we are specially trained as the nutrition experts to do that. Patients that are identified with moderate or severe malnutrition then become eligible for measure observations 3 and 4. Number 3 is a medical diagnosis of malnutrition, which should be documented by the physician or other eligible provider, depending on state or local regulations. And then number 4 is the development of a nutrition care plan. Typically, we see those sort of as nutrition interventions. The word care plan can be a bit confusing because of the way EHRs use the term care plan, but typically it's sort of that bundled intervention, monitoring, and evaluation approach that dietitians complete. To calculate the score, completion of each one of those 4 components is summed. So if it is done, they receive a score of 1. If it's not done, they receive a score of 0. And then it's divided by the number of clinically eligible occurrences. And that really allows for scoring to be done based on a patient's severity or presence of malnutrition risk and or malnutrition. So for example, if a patient receives a malnutrition risk screening and is identified to be not at risk for malnutrition, and there is no dietitian referral ordered, then measure observation stops there, right? Because we wouldn't expect that patient to be receiving any more care because they have not been identified as at risk. So in that situation, they would receive a 1 for performing the component, which then would be divided by the clinically eligible occurrence, which would be 1 in this situation, to give them a 100%. The individual encounter scores are then summed together to generate a facility level GMCS score. Higher performance scores indicate better performance, so you want to get as close to 100% as possible, knowing that no one will be receiving a 100%. Next slide, please. So every year we go through a very robust annual update or AU process with CMS and Mathematica, who is the contractor that CMS uses to sort of drive a lot of this work. So my team and I have been working diligently to update the measure that will start in 2025, the updates, to better reflect both clinical practice and what we feel much more fairly score performance. We gather a group of individuals known as a TEP, our technical expert panel, who we talk to get their input, people that are really currently practicing, patients, advocates, physicians, et cetera, to make sure that we're really capturing what is happening out in the world. So the first big exciting change is that the presence of a hospital dietitian referral order can now count as completion for measure observation 1 or the malnutrition risk screening. So if you remember, as I said before, historically, it just sort of allowed bypassing of the screening to allow a patient to become eligible for the assessment scoring, but it did not count as completion. Now, the presence of the referral counts as completion of the screening. We recognize oftentimes in clinical practice, a nurse might put in a referral in the absence of completing a screening because he or she knows that the patient likely needs an assessment. And so we're thrilled to make that change. We also updated nearly all of our value sets. So value sets are a series of codes that are used on the back end of your EHR to map whether or not measure observations were completed. So we were very happy to update those value sets primarily in the malnutrition diagnosis component to make sure that we were really capturing all the codes that a physician or eligible clinician would be using to diagnose malnutrition. We also resolved a known issue. So for those of you that have been working on implementation or working with others who are implementing, we identified over the course of this annual update cycle a known issue that was leading to erroneous calculations. Basically, it would continue calculating measure observations, but the eligible occurrence would stay at 1 or 2. So it would generate scores over 100%, which is of course not the intent of the measure. So we did update those eligible occurrences to eliminate that known issue, and also we feel more fairly score. So now if there is no screening, the eligible occurrence is 1, where historically it was 4. So you were sort of held responsible for all of those components, even though you didn't really have a chance to do them. And likewise, in the absence of an assessment, the eligible occurrence or denominator is now 2, again, not holding you responsible for measure observations 3 and 4. We also changed the timing of the malnutrition diagnosis for inclusion. So historically, every measure observation had to be completed either during the inpatient encounter or during the any emergency department or observation encounter that was tied to that inpatient encounter. But as many of you likely know, many patients are diagnosed with malnutrition on previous encounters, and then that diagnosis carries over from encounter to encounter. The way the measure worked before, those diagnoses were not included because it didn't start during the current encounter. So we have adjusted that. We have adjusted the measure so that as long as the malnutrition diagnosis is active during the current eligible encounter, then it can be used for completion of measure observation 3. So again, these are updates we're excited about because we really feel it's going to help improve measure performance scores and really more accurately mirror what's happening out in clinical practice today. Go to the next slide, please. Okay, and so I think by far the most exciting change is our population expansion. So a couple of weeks ago, CMS released the Inpatient Prospective Payment System proposed rule that did include a proposal to expand the measure population from adults aged 65 years and older to all adults aged 18 and older. This was actually done at the request of CMS. So about, oh gosh, a year and a half ago, CMS came to our team and asked us to go through really this formal rulemaking process to expand the measure population because they, CMS, recognize the importance of malnutrition in all hospitalized adults, not just older adults. So we were so excited to be able to do this work and then to see that published in the proposed rule. All of the other inclusion criteria remain the same. So inpatient admissions must still be 24 hours. But again, now we can include adults aged 18 and older. We'll talk about it in a moment, but they in the proposed rule recommend that this go live for calendar year 26. So I have the next slide really talks about timing, but I think that's an important note that we're going to talk about when you do commenting, how you can include details there. So in the proposed rule, they comment on some concerns that were identified during a series of meetings that we attend leading up to the publication of the proposed rule. So there's a group of experts called Primer, pre-rulemaking measure review, who basically gather input from the public as well as from experts on quality measurement to give input on whether or not measures should be considered by CMS. And if they are considered, maybe some other points that should be included. A couple of things that they identified were that one, the measure should include feedback from additional patient groups. So the concern raised was related to whether or not a patient would retain autonomy in their ability to accept or decline nutrition interventions. And so as part of our comment, and perhaps comment that you might want to make, the measure was developed with input from that national dialogue that was done a few years ago, which really gathered input from many different stakeholders, including extremely strong input from patient groups and patient advocate groups. And the measure does allow for completion of scoring for the nutrition care plan even if a patient refuses any intervention or declines that intervention. So I think, as dietitians, we respect a patient's autonomy and their ability to make decisions related to their care, and the measure does not penalize organizations for patients that do not choose to participate in their care. So I think that's a really important point. The other request or issue that was raised during these committee meetings that was put into the proposed rule is about hospital-acquired malnutrition and high-risk nutritional practices. So it will be no surprise to any of you that we as healthcare providers induce quite a bit of malnutrition in the hospital through a variety of ways, overly restrictive diets, unnecessary prolonged fasting, inadequate delivery of enteral or parenteral infusions. And so, of course, we recognize that that's absolutely happening, and that is extremely important. And so the way that the measure is designed is that it does not preclude rescreening or later referrals. So let's say a patient is admitted to maybe a gen med unit. They're identified to be not at risk by the malnutrition screening, but later in the admission something happens, they get admitted to the ICU, and a hospital dietitian referral order is placed. Now that referral order is going to sort of supersede that not at risk screening and make them eligible for the later components. Again, timing doesn't matter. So the components can be completed in any order at any time during the eligible encounter, because we want to make sure that we're capturing care provided as a result of hospital-acquired malnutrition. So if you read the proposed rule and/or some summaries of it, those I think are the two main criticisms that we've seen of the expansion, and how we have responded and encourage others to respond to that feedback as well. Next slide, please. So this is the timeline. I think understanding quality reporting timing is painfully confusing. And so our team created this, this sort of map to help you. So right now we're in calendar year 24. You see that's highlighted in purple. So basically the way that reporting structures work is what they have is called a reporting period. And I would liken that to sort of data collection. So right now we're in reporting period calendar year 24. So hospitals are actively recording data, gathering data from January 1 to December 31 of 2024. Then the next year is what we call the submission period. So typically they have until March or April to submit the data from the year previous. So submission period calendar year 25 will include data from calendar year 26. The payment period is then when their payment is affected by the reporting. As I mentioned, IPPS or IQR is a pay for reporting, not pay for performance. So basically they receive a reimbursement amount for meeting the criteria for reporting rather than what their actual scores are. And that change in reimbursement comes in then the next fiscal year. So that would be fiscal year 26. So there's really a significant lag in when the data is actually collected to when it's reported to when it impacts payment. And as I mentioned, right now we're in calendar year 25. Those updates that I reported to you will go live for calendar year, we're in calendar year 24. The updates that I reported will go live in calendar year 25. And CMS's proposed expansion of the measure population to 65 plus, they're recommending for calendar year 26. We as an organization, and I believe Defeat Malnutrition as well, is encouraging CMS to move up that adoption to calendar year 25. So along with all those other changes that I mentioned, expanding the measure population in calendar year 25 rather than waiting for 26. For a variety of reasons. Of course, we know that malnutrition is impacting people today, but most importantly, it will not add any burden to reporting facilities. They're already collecting age as one of the elements that they have to report. So assuming, that they've already built out all the infrastructure for reporting, adjusting the population to include all adults will not add any additional burden to implementer facilities. Can you go to the next slide, please? So these are just some quotes that have come from CMS about why they believe the GMCS to be important. As I mentioned, they did come directly to us as the measure stewards, asking us to expand the measure population, which is sort of unusual in the way that this work is done. So that alone, I think, really speaks to the fact that CMS recognizes the role of malnutrition in hospitalized patients and why the GMCS is important for providing standardized, high-quality malnutrition care. So the first quote is about how identifying malnutrition during the admission process can help with reduced readmissions and length of stay. Of course, we have a robust amount of evidence out in the world that demonstrates that people that have malnutrition have longer lengths of stay, typically have higher costs of care because of additional comorbidities. But also we have evidence that people with malnutrition who receive a structured nutrition care plan have better outcomes than their malnourished counterparts that do not receive that care plan. So again, GMCS is going to incentivize facilities to make sure that they have processes in place to provide high quality malnutrition care. The malnutrition measure also addresses priority areas, including the CMS equity plan for Medicare. And that's because, as you all know, malnutrition disproportionately impacts people based on individuals of color, people of low socioeconomic status, et cetera. So one factor contributing to the burden of malnutrition is health disparity across racial and ethnic groups. So again, not only are we addressing the role of malnutrition, but we're starting to touch on that very difficult concept of health equity and addressing health disparities in the acute care setting. Can you go to the next slide, please? So again, this is more information about how malnutrition is caused by a myriad of factors, but including food insecurity. And individuals coming from underserved populations typically experience health inequities much more frequently, including malnutrition. And adopting the measure would lead to a more diverse population being assessed by malnutrition, and therefore also including individuals of younger populations who are then going to benefit from proper nutrition over a longer period of time. You know, obviously we want to identify and treat malnutrition at any age, but if we can intervene sooner, then theoretically we're going to improve a person's quality of life for a much longer period of time than if we're only focusing on identifying and treating malnutrition in older adults. Next slide, please. So these are some, when we talk to groups about why they should report on the GMCS, because it is a self-selected measure, we talk about health equity all the time because, you know, in terms of healthcare leadership, addressing health equity is a priority for basically every care setting, but really impacting it is extremely difficult, right? Lots of times it requires significant effort, significant cost. But when you think about GMCS and treating malnutrition, you're able to sort of touch on all of those things with a process that probably already exists in the facility. So the GMCS, of course, addresses nutrition screening requirements, which are currently by the Joint Commission, but also really addressing social determinants of health and food insecurity, health equity advancement, and rural health improvement. So again, we're able to sort of get to those inequities that can be incredibly difficult to both capture and impact by using a standardized process that we already know and is likely being employed in facilities today. The GMCS also combines several quality measures. So as I mentioned, we have those 4 measure observations, and that's helpful because it really helps identify strengths in different parts of the process within a facility rather than just looking at the overall score. So it can be incredibly helpful for a hospital to see that perhaps they're performing very poorly on measure observation 3, which is the malnutrition medical diagnosis, which is then bringing down their overall score. And they're able to really focus their QI, PI efforts on improving that aspect rather than trying to, you know, really tackle the whole ball of wax, which is likely not going to be efficacious. And finally, providing care that is measured by the GMCS is likely to align with a hospital strategic plan, mission, vision, values, all of those things that are addressing social determinants of health and equity. And as we know, that is becoming increasingly important across the healthcare spectrum, but certainly in the acute care population. Next, please. So in order for successful GMCS implementation, you really have to engage a wide variety of stakeholders. One, right, so the GMCS is intentionally interdisciplinary, right, because that is the way that malnutrition care should be provided. So we're going to be including physicians or other eligible clinicians, of course, in that malnutrition diagnosis component. Other healthcare professionals maybe be doing screening if nursing is doing that, but also care planning, right? If you have to perhaps work with social work, maybe PT, OT, depending on the needs of your patients. Hospital executives are going to be required in order to allocate specific resources. Often those are needed for either, you know, adjusting your electronic health record or adjusting processes to make sure that GMCS components are being met. Obviously, the clinical nutrition team is going to be paramount to the success of GMCS. So you're going to have to make sure that the clinical nutrition team is performing assessments appropriately, using validated tools, and documenting those in a way that can be captured easily. and then working with your EHR and IT companies to make sure your EHR build is really optimized for data reporting and gathering. We know that AI has allowed for EHRs to capture more free text out in notes, but it is expensive and time consuming. And so if you can build your EHR to include many discrete fields of, drop downs, pick lists, et cetera, it's much easier for your EHR then to generate reports related to GMCS reporting rather than relying on unstructured notes. So this is the general structure of quality, a process improvement. I know Laura's going to talk about it a little bit. We just include this as sort of a high level of what you might expect when doing a process improvement project related to the GMCS. Generally, we recommend trying to separate each one of the 4 measure observations and approaching them individually, knowing that those efforts are likely going to overlap. But again, if you try to fix the whole problem, you're probably not going to get anywhere versus focusing just on one of the measure observations at a time. The other note here is that this looks sort of linear, but any of you who have ever done process improvement know that's not how process improvement works, right? You're likely going to move through this process. You might hop from step to step, and more likely than not, you're going to go backwards a few times. You might come to a solution that you think is going to work. You test it out and you find out maybe the outcome isn't exactly what you would think. And so you have to go back and redevelop solutions, retest solutions, et cetera. So I think it's really important to maintain realistic expectations when doing QI and PI, that you're not going to get it right the first time. QI, PI is a continuous process that never ends. So really aligning your team with expectations that this is going to be going on forever, which doesn't mean you're not succeeding. It's just sort of the nature of this work. And with that, I think I turn it back to Laura.
Yes, thank you. That was a great in-depth view of the GMCS. And we just wanted to add in a few notes about that you need to have this quality improvement process to implement the GMCS. As Anne mentioned, in many cases, hospitals are screening more than just the 65 plus patients, but aren't reporting on it. So you need to engage with the quality improvement team. Here's some of the roles they can play, and engage with IT, again, so that you can make this process easier. And so how to comment. One of the most important things that we hope you take away from today's webinar is the need to have diverse groups comment. So the proposed rule went live today, and comments are due by 5 p.m. on June 10th. And you can submit electronically at regulations.gov. And some general guidance on what your comment could contain. You thank CMS for proposing this expansion, for acknowledging the significant impact that malnutrition has on all adult patient outcomes. You could discuss that malnutrition care gap and the health equity implications of addressing malnutrition. And then, as DMT will be recommending, you could also recommend an accelerated timeline. So this takes effect in calendar year 2025 reporting instead of the proposed calendar year 2026. And so we will provide a comment template and some guidance in the materials we send after the webinar. And with that, I'm gonna turn it over to Bob to finish it up.
Thank you, Laura. And yeah, I agree with Laura. Thank you, Anne, for a very thorough presentation, and one that helps everybody get a better grip on this topic, which, thanks to you, is not as complicated as people might think it would be. So thank you for that. So why comment? Well, let's talk for a minute about, I'm going to assume people that are on here have an interest, but they also are advocates. And advocacy, oftentimes people just sort of pigeonhole and say, oh, that's just dealing with Congress and legislation and things of that nature. But that's really not the case. Commenting, public comments on rules can make a huge difference as to whether they go from proposed to final, both in the positive way or the negative way. And over the course of time, when you have lots of comments that come in, particularly when they're individualized, the agency involved, in this case CMS, takes notice. And This particular comment is a great opportunity for people to be more inclusive, to identify malnutrition and food insecurity earlier and the linkage between the two, an opportunity to highlight the crucial role that nutrition plays in improving patient outcomes, which is extremely important to CMS in this particular time. And your comment can help ensure that malnutrition is in fact elevated. Preventing malnutrition is elevated as a national priority. And we know from what's been said earlier that expanding the GMCS will not only help address malnutrition care, but it's going to also help address health disparities because of the unique role social determinants of health play in the development and progression of malnutrition. And for those of you in the SDOH space, the more you can elaborate on that point in your comment, I think the more effective that comment will be and the more influential that will be. Next slide. And then, of course, something that we have been spending our time on since the first version of the Global Malnutrition Score came out. Can we go to the next slide between these slide operators here? I'll go. Okay, here we go. So we can't emphasize this point enough. It's really important, and this comment can help do this, to connect local healthcare providers to their community-based nutrition programs. When the individual who may have been diagnosed with malnutrition reaches the point of discharge, to avoid that readmission, which hospitals get penalized for, it's important there be a relationship established between a healthcare provider and community-based nutrition programs. And, the point you want to make is both from the standpoint of lowering the burden to the hospital caused by higher readmission rates, but you're ultimately saving critical Medicare dollars by the adoption and expansion of the Global Malnutrition Score. And it also adds new relevance to an existing network that's been there for, in some cases, more than 50 years of community-based nutrition programs who are equipped to help address these new nutrition care plans and these new individuals who may be coming their way. But at the same time, we have to be realistic to know that if we increase the number of people seeking community-based nutrition, we need to have the resources to ensure that they can be served. But this can provide a new incentive to increase the funding for programs like the Older Americans Act nutrition programs and food bank programs and the rest. So there's more than one dimension associated with commenting on this rule. It's a health rule, but it's also an opportunity to connect the importance and the relationship between nutrition and health. And next slide. So the question of what are the opportunities to increase referrals or obtain further funding? Well, for community-based organizations, it's important that there be a connection made, if there isn't one already, to connect with the local hospital's discharge planners for referral purposes. And that's a relationship that is so vital to the success of the malnutrition quality measure. And then for funding, to check into the Aging and Disability Institute, Business Institute, for further thoughts on business acumen and making the value case for the services. And then for healthcare providers, start to understand that there are existing tools out there that can make the ability to connect with the local provider easier, such as the Elder Care Locator operated by U.S. Aging, or the Meals on Wheels America Find Meals site. That allows the all-important referral of the patient to be done quickly. Days count, hours count in these kind of situations. And you need to have both the patient prepared to go and also the community-based nutrition group ready to take the individual on as a new client, if you will. And then also for healthcare providers, for funding, to work with local organizations to get what are given out on an annual basis as innovation grants from the Administration for Community Living, or private foundations for pilot funding for something larger like a produce RX program or medically tailored meals. And there is more activity on a funding basis in that space, thanks to work that's been done over the past couple of years, focusing on medically tailored meals, culturally appropriate meals, all those aimed at being able to connect the nutrition with improved health outcomes and not readmitting individuals to that hospital. So we will close with a slide with a series of resources. We'll keep this slide up while I turn it back to Laura for any questions that may have been generated for any of the three of us. So thank you.
Yeah, if anybody has questions, you can raise your hand or you can write into the chat. And if there aren't any questions, Anne or Bob, do you have any parting thoughts they would like to say as we wrap up today's webinar?
I just want to thank you all for your support. I mean, I think my team and I are thrilled to have support from individuals like yourselves, from organizations. We absolutely could not do this kind of work without people like you. So thank you. And we are happy to support you in any way in commenting, like Laura said. But yeah, absolutely. Thank you for all the support and the great work that you all are doing every day.
Let me echo thank you to you, Anne, and to the work of you and the measure stewards in getting the first quality measure together, and now the positive development of expanding it to 18 plus. My comment would be, we produced this webinar for a very specific reason, which is to generate as many comments as we can between now and June 10th to get as wide a variety of individuals, stakeholders, if you will, to lay out the importance of this. And I'm going to add, it's important to localize your comments. Okay, where can it benefit your community? What can you, if you live in an area, for example, with a large population of older adults, that could be an important fact to throw in. If you know for a fact that there is existing relationships between hospitals and healthcare systems and community-based nutrition programs, say that this can only enhance that relationship and make it better. So it really is about, not getting too deeply into the weeds about the quality measure as much as it is what its impact would be and what its meaning could be for the day-to-day individual that you may serve, that you may work with, or that you may know. And we are hopeful that everybody on this webinar, as well as those you can join us in getting the word out to people that would have an interest in this, to encourage them as well to make comments. And please, don't be shy about reaching out to us with questions. We'll have a template available very soon for you to follow. But more importantly, let us know if you do file a comment, because we want to keep track of that. And we think the more the better. And we do have 5 weeks basically to do this, which should be plenty of time. And we encourage you to do that. So with that, I'll turn it back to Laura, see if anybody has any questions. But with Anne's fabulous presentation, I can imagine it was so self-explanatory. There's no need for questions,
Yeah. All right. Seeing no questions, thank you everyone for being here today, and we will be in touch. Have a good rest of your day.